interesting topic that does bone marrow morphology actually matter in MDS in 2022. So starting with the definition of myelodysplastic syndromes, it is a diverse group of clonal disorders of hematopoietic stem cells. It is most common cause of acquired bone marrow failure syndrome in adults, which is characterized by ineffective hematopoiesis resulting in cytopenias, dysplastic morphology, and recurrent genetic abnormalities resulting in clonality with the potential to further clonal evolution to AML. So the current MDS diagnostic criteria require peripheral counts in order to demonstrate cytopenia in one or more lineages, morphology in order to demonstrate dysplasia. Dysplasia should be more than 10% in at least one of the myeloid lineages, that is either erythroids, granulocytes, or megakaryocytes. Morphology is again required to enumerate the percentage of the blasts in the peripheral blood or the bone marrow, and to see the ring sideroblasts based on Pearl stain. And karyotyping is required to prove clonality. So starting with the various types of dysplasia in erythroid lineage. So in patients with MDS, there could be erythroid hypoplasia with dysplastic changes. Like we can see here, this is a multilobated erythroid, multinucleated. This is again a multinucleated erythroid. This is a megaloblastoid change where the nuclear chromatin is opened up and sieve-like. This is again multinuclearity. There could be nuclear pycnosis with a shrunken chromatin, and there could be basophilic stippling. This is nuclear lobulations, cytoplasmic vacuolations and fraying, and ring sideroblast. Ring sideroblast is an abnormal sideroblast characterized by at least 5 or more siderotic granules in the perinuclear region covering at least 1/3 of the circumference. So coming to the dysplastic changes affecting the granulocytic lineage, in MDS, there could be an increase in the blasts in the bone marrow ranging from 5 to 19%. Even a single blast with an OR rod, as we see here, would put the patient under the diagnosis of MDS with excess blast 2. There would be hypogranularity and hypolobation of the myeloids, as we see here and here in B and C. Abnormal chromatin clumping, as we see here, abnormal lobulations, and hypogranular myeloids. In the peripheral blood, you may observe pseudo-Pelger-Hue anomaly, which is a bilobed neutrophil, which appears like a spectacle with 2 lobes joined by a thin bridge of chromatin, and which is also hypogranular. There could be abnormal nuclear lobations, as you see here, or there could be hypogranularity of the myeloids. Coming to the dysplastic features affecting the megakaryocytic lineage, the most specific dysplastic morphology is presence of a micromegakaryocyte. If there is micromegakaryocyte, the diagnosis is most often MDS. A micromegakaryocyte is a small megakaryocyte which is equal to or smaller than that of a promyelocyte and which is non-lobated or hypolobated, as you see here. This is another dysplastic megakaryocyte with widely separated nuclei. This is a small binucleated megakaryocyte, and this is a large monolobated megakaryocyte. So all these are different dysplastic forms of megakaryocytes. So this is an interesting case that we had reported. This is a case of MDS with isolated 5q deletion. This is observed more commonly in women, usually presents with anemia with a normal or elevated platelet count. The bone marrow morphology is quite classical in the sense that there is erythroid hypoplasia and proliferation of hypolobated megakaryocytes, as you see here. On cytogenetics, there could be 5q deletion, and it usually has good prognosis. The bone marrow biopsy also has an important role in the diagnosis of MDS because normally the immature myeloid precursors and the myeloblasts are located paratrabecularly. However, in MDS, there could be an abnormal localization of these immature precursors, and they would appear either in aggregates or clusters in the center of the bone marrow away from the trabeculi, and they can be highlighted by using a CD34 immunostaining. So this is the current diagnostic classification of MDS as per the revised WHO. So it classifies MDS as MDS with single lineage dysplasia, MDS with multi-lineage dysplasia, that means dysplasia affecting 2 or 3 lineages, MDS with ring sideroblasts, MDS with isolated deletion 5q, MDS with excess blast 1, which is characterized by 5 to 9% blast in the bone marrow or 2 to 4% blast in the peripheral blood, and MDS with excess blast 2, which is characterized by 10 to 19% blast in the bone marrow or 5 to 19% blast in the peripheral blood, or as I mentioned, even a single blast with an OR rod with a total blast count of less than 20% would put the patient in the diagnosis of MDS excess blast 2. And the remaining MDS types are MDS unclassifiable. Now, as per the previous WHO classification, it required morphological enumeration of at least 15% ring sideroblast on a pearl stain smear in order to classify the patient as MDS with ring sideroblasts. But it is now found that if the patient has a characteristic mutation called SF3B1, then even 5% or more ring sideroblasts are sufficient to call the patient as MDS with ring sideroblast. Now, if you look at this classification, it is quite clear that almost all the subtypes of MDS require morphological evaluation of dysplasia in order to identify them, except for this last subtype, which is based on defining cytogenetic abnormalities. So it is now known that this list of mutation, cytogenetic abnormalities are MDS defining cytogenetic abnormalities, which means that if a patient has any of these abnormalities with persistent cytopenia, the patient can be diagnosed as MDS even without the presence of morphological dysplasia. So does that mean that now it is time to say, okay, enough and goodbye to morphology, and we can only rely on cytogenetics to diagnose MDS in a patient with persistent cytopenias? Well, the answer is no, because these recurrent cytogenetic abnormalities identified by conventional karyotyping are present only in around 50% of the MDS cases. So by using cytogenetics, you would miss out on the diagnosis in large number of MDS cases. So the combination of both overt marrow dysplasia as well as clonal cytogenetic abnormality definitely allows a conclusive diagnosis of MDS, but this is found only in a small portion of the patients. In most of them, cytogenetics may not be informative, and hence the diagnosis of MDS then relies entirely on morphological criteria. Morphology is not only important for diagnosis, but it also plays an important role in prognostic stratification. So looking at the revised International Prognostic Scoring System, RIPSS, the WHO-based prognostic scoring system and the original IPSS, all of them require morphology either for enumeration of the blast percentage or to categorize the patient into different WHO subtypes. So looking at the WHO classification-based prognostic scoring system, it is very clear that a patient with unilineage dysplasia has a better overall and leukemia-free survival as compared to a patient with multilineage dysplasia. Again, going further, a patient with excess blast 1 has a better survival as compared to a patient with excess blast 2. So morphology does provide useful prognostic information. On the other hand, the revised International Prognostic Scoring System now says that if a patient has less than or equal to two blasts, he's given a different prognostic score as compared to a patient with more than 2 to less than 5 blasts in the bone marrow. So now it is very important to report the exact blast count based on a differential count on at least 500 all nucleated cells on the bone marrow. And a flow cytometry-based blast enumeration cannot replace or substitute morphological blast count. So this was another study done to assess the effect of prognostic effect of evaluation of bone marrow dysplasia by morphological score. So here an objective score was assigned to each dysplastic features and it was tried to grade the extent of dysplasia. So higher the score, higher is the extent of dysplasia. So it is quite interesting to see that as far as the erythroid lineage is concerned, irrespective of the score, there is no change in the prognosis or overall survival. However, for myeloid and megakaryocytic lineage, as the morphological score of dysplasia or the extent of dysplasia increases, the overall survival decreases. Also, a patient with all the three dysplastic lineages will have a poorer overall survival as compared to a patient with 2 or 1 dysplastic lineages. Coming to the recently identified recurrent mutated genes in MDS, now with the easy availability of next generation sequencing, at least 50 genes have been identified to be mutated in MDS cases. And these mutations, one or more, are present in at least 90% of the MDS cases. Moreover, these mutations also have prognostic significance in the sense that they would provide useful clue about favorable or unfavorable prognosis. There are also certain studies which say that addition of these mutations would further improve the prognostic risk stratification by using revised IPSS. So, does this now mean that it is time to say, okay, enough and goodbye to morphology and throw away morphology in the books of history and say we can only rely on NGS in a patient with cytopenia to arrive at a diagnosis of MDS? So where does morphology actually fit in the MDS diagnosis in today's era of molecular testing? Well, the answer still remains the same. You still need morphology because you must understand that there are certain major caveats with the molecular testing. Because most of the mutations, with the exception of SF3B1, do not appear to correlate with a specific disease entity. Moreover, it is important to be aware of the terminology CHIP, that is clonal hematopoiesis of indeterminate potential. So it is now known that at least 10% of healthy individuals aged more than 65 years would harbor one or more of these somatic MDS type of mutations in their hematopoietic cells, but they would be completely normal and would continue to live a normal life. So studies have shown that with increasing age, the prevalence of these MDS type somatic mutations increases, but these patients will have absence of any definite morphological evidence of hematological neoplasms. And these MDS taxomatic mutations are present at a significant variant allele frequency of at least 2%. But just like a patient with monoclonal gammopathy of undetermined significance would usually continue to live a normal life and may never progress to myeloma or plasma cell leukemia, or a patient with monoclonal B-cell lymphocytosis is also considered benign and may never progress to CLL or Richter's transformation. Similarly, a patient with CHIP has very low incidence of progression to MDS or AML, and they most of the times continue to live a normal life. Thus, presence of any of these MDS-associated somatic mutations alone are not considered diagnostic of MDS, even if they are present in a patient with persistent or unexplained cytopenias. So it is now known that there are patients with cytopenias who may or may not have these clonal mutations. So that is known as idiopathic cytopenia of undetermined significance or clonal cytopenia of undetermined significance. But it is only the recognition of cytological dysplasia based on morphological examination, which remains the cornerstone for identification of MDS and to differentiate MDS from these relatively benign conditions like CHIP, CCUS, or ICUS. So let us look at some interesting cases. So this is a 48-year-old man who came from Bihar and presented with fever, weight loss, pancytopenia for 6 months. Looking at the bone marrow examination, we can see that there was significant dyserythropoiesis with binucleate erythroids. This is trinucleate erythroids. This is an erythroid with 4 nuclei and basophilic stippling. So the dysplasia was there in more than 10% of the erythroids. So this possibly brings us to the diagnosis of MDS with single lineage dysplasia, right? But on further careful morphological examination of the bone marrow aspirate, what was found was one of the histiocyte had a nucleus and a kinetoplast. So this was a case of visceral leishmaniasis. So on probing further into the clinical examination, it was found that this patient had hepatosplenomegaly, which is highly unlikely in a case of MDS, and the patient also had skin nodules. So the take home from this case is that possible reactive etiologies of dysplasia should always be carefully considered before jumping to the diagnosis of MDS, particularly when the dysplasia is limited to one lineage. Looking at another case, this is a 50-year-old man who presented with 7 months history of weight loss and transfusion-dependent anemia. The bone marrow examination again showed significant dyserythropoiesis with megaloblastoid maturation. There were multinucleated erythroids, nuclear lobulations, and pycnosis. And the iron stain showed presence of more than 15% ring sideroblasts. So there is transfusion-dependent anemia since a long time, and there is dyserythropoiesis with ring sideroblasts, possibly a diagnosis of MDS with ring sideroblasts and single lineage dysplasia. But again, on probing further into the history, this was a known case of pulmonary tuberculosis, was on long-term treatment with isoniazid. So it is very important to understand that sideroblastic anemias could be congenital or acquired. And acquired causes of ring sideroblasts are quite common, which include drugs like isoniazid, linezolid, penicillamine, pyridoxine deficiency, zinc poisoning, or alcohol consumption. So these conditions must be excluded before jumping to the diagnosis of MDS. Looking at another case, this is a 52-year-old lady who presented with generalized weakness and pancytopenia. On examination, there was no organomegaly and no lymphadenopathy. The bone marrow examination showed dyserythropoiesis with binucleate erythroid, a separated nuclear lobe, abnormal mitosis, and megaloblastoid maturation. Seeing further fields, again, there was dyserythropoiesis, abnormal nuclear segmentation of the granulocytes, and a megakaryocyte with separated nuclei. So all the 3 lineages were showing significant dysplasia. So possibly a diagnosis of MDS with multilineage dysplasia. Now, going back to the peripheral blood film of this patient, what was observed was, it was a classical blood picture of macroovelocytes with hypersegmented neutrophils. So this is what is commonly observed in megaloblastic anemia as against MDS, where you would usually see macrocytes and not macroovelocytes. And classically, you would see pseudo-Pelger-Hue neutrophil, which is a small hypolobated and hypogranular neutrophil. Now, looking at the volume, conductivity, and scatter parameters of this probable megaloblastic anemia with a classical MDS, on this scatter plot, the y-axis indicates the volume and the x-axis indicates the scatter. Scatter corresponds to granularity. Now, if you can see, it is very clear that these neutrophils are very large. So looking at the scatter plot, the neutrophils are higher up along the y-axis with a very high volume of 190 as compared to MDS, where the neutrophils are small, lower down along the y-axis with a small volume of 140. Looking at the conductivity corresponds to the nuclear lobes. So this is a hypersegmented neutrophil. So the conductivity is significantly high, 154. Whereas in MDS, the conductivity is reduced because of hypolobation. It is only 138. Looking at the scatter parameters, which indicates the granularity, You can see that the scatter here in the case of probable megaloblastic is normal. It is 143, and the neutrophil cluster is well separated from the monocyte cluster. On the other hand, in a classical MDS, because of hypogranularity, the neutrophils are merging with the monocytes with a very low scatter of 126. So looking at the cell counter parameters, it is quite suspicious that our case is possibly megaloblastic and not MDS, even though there was significant dysplasia. So when we looked at the other lab parameters, the patient had a low B12 level, and it was actually a megaloblastic anemia. So a severe megaloblastic anemia can have severe dysplasia and can mimic MDS, but you always have to look at other lab parameters before jumping to that diagnosis. This is yet another case of megaloblastic anemia because of anti-folate chemotherapy in a 57-year-old woman who was receiving the chemotherapy because of breast cancer. You can see that there is significant dysplasia, megaloblastoid maturation, binucleate erythroids, multinucleate, nuclear lobulations, significant dysplasia, but not MDS. This is another case of chronic arsenic poisoning because of occupational exposure. You can see that there is marked dyserythropoiesis, but the history of toxin exposure makes the diagnosis clear that it is not MDS. So what I want to say is dysplasia is not specific for MDS. Dysplastic changes can also be seen in patients with non-neoplastic or reactive cytopenias. And also, it has been found that more than 10% dysplasia can be there in the bone marrow of healthy bone marrow donors. So it is very important to differentiate the MDS from other clonal and non-clonal causes of dysplasias and cytopenias. So just like these two sisters who actually look very much alike, but on careful observation of their behaviors over a period of time, you might realize that one of them is a demon and other is an angel. It is very important to differentiate MDS from other reactive or benign non-MDS mimics, which can be easily treated. So coming back to the same question with which I started today, does bone marrow morphology actually matter for the diagnosis of MDS in 2022? Well, I hope that the answer is very clear. Yes, it does matter. It provides very useful information, provided you beware of the potential copycats, imposters, and imitators, and you avoid the diagnostic pitfall and do not mislabel a benign or reactive condition as MDS. So a good morphologist should not be like any of these 6 blind men who are just touching a part of the elephant and jumping to the diagnosis, where one who is touching the ear says it's a fan, one who is touching the tail says it's a rope. But you have to look at the entire elephant as a whole to arrive at the diagnosis. So similarly, the diagnosis of MDS is also comprehensive. It requires a detailed clinical picture, history of drugs, toxin exposures, lab tests like B12 folate, peripheral smear examination, bone marrow, and cytogenetics. These remain the mandatory criteria. In addition, presence of FISH or molecular testing would certainly provide useful additional information. But in spite of all that said, morphology remains a cornerstone for diagnosis of MDS. So I would like to thank you with dysplastic neutrophils. It is quite interesting to see that these are actual pictures of dysplastic neutrophils taken from an 80-year-old man. And this is published in the Journal of American Society of Hematology, where the neutrophils were so dysplastic that they mimicked alphabets from A to Z. But you would be surprised to know that in spite of such significant dysplasia, this man did not have MDS. So the conclusion is just the way all that glitters is not gold, all that is dysplastic is not MDS, but in spite of all that, morphology remains the cornerstone for diagnosis of MDS, even in 2022. Thank you very much.